Okay, to finish out Unit 2, in Lecture 3, we're going to start with blood and go through the rest of the tests on the reagent strip. So blood can be present in the urine either in the form of intact red cells, which is referred to as hematuria, or as the product of red cell destruction, which is known as hemoglobinuria. So we talked about it a little in chapter 2, so you know that blood in large amounts can be seen macroscopically. Hematuria produces a cloudy pink to red urine, whereas hemoglobinuria will result in red but clear sample. Reagent strips are more accurate at detecting blood than a microscopic examination because the strips detect blood in much smaller amounts than are able to be seen with the naked eye. After blood has been detected by the reagent strip, the microscopic exam can then be valuable in differentiating between hematuria and hemoglobinuria because red cells due to hemoglobinuria would not be visible in the microscopic examination. So it's just some different conditions there that can be seen associated with hematuria and then with hemoglobinuria. So a positive reagent strip test for blood indicates the presence of red cells, hemoglobin or myoglobin. So, and each one of those is going to have different clinical significance. Let me back up here for just a second, sorry. So with hematuria, and again, that reagent strip can detect intact red cells, hemoglobinuria, or myoglobinuria. With hematuria, you've got intact red cells with a cloudy pink to red urine. Hematuria is most closely related to damage of the organs in the renal or genitourinary systems. Some major causes are renal calculi, glomerular diseases, tumors, trauma, pyelonephritis, exposure to toxic chemicals, and anticoagulant therapy. Non-pathologic hematuria can be seen following strenuous exercise or during menstruation. Many times when a patient presents with severe back and or abdominal pain, a urinalysis is important in diagnosing kidney stones, in which hematuria is usually present only in a small or maybe moderate degree. But even though there may not be a large amount of blood, the presence of blood is essential to the diagnosis. Okay, with hemoglobinuria, the urine will be clear and red. It results from the lysis of red cells, especially in dilute alkaline urea. It can also be caused by intravascular hemolysis, followed by the subsequent filtering of hemoglobin through the glomerulus. With lysis of red cells in the urine, you'll usually see a mixture of hemoglobinuria and hematuria, but with intravascular hemolysis, there are usually no red cells seen. Hemoglobin is usually not available for filtration by the glomerulus because under normal conditions, it's bound to haptoglobin, which is a protein produced by the liver that transports free hemoglobin back to the liver for recycling. But in conditions such as hemolytic anemias, transfusion reactions, severe burns, brown recluse spider bites, infections, and strenuous exercise, the amount of free hemoglobin exceeds the haptoglobin content, so hemoglobin is available to the glomerulus for filtration. Reabsorption of the filtered hemoglobin also results in the appearance of large yellow to brown granules of denatured ferritin. Ferritin is the storage form of iron found in the spleen, liver, and bone marrow. This is called hemosiderin, which is an insoluble form of ferritin in the renal tubular epithelial cells and in the urine sediment. And then myoglobinuria produces a clear red to brown urine. Myoglobinuria is, or myoglobin is a heme-containing protein found in muscle tissue. This should be suspected in patients with conditions associated with muscle destruction, such as trauma, crush injuries, prolonged coma, convulsions, muscle wasting diseases, alcoholism, heroin abuse, and extensive exertion. The heme portion of myoglobin is toxic to the renal tubules, and high concentrations can cause acute renal failure. So a little bit of information on hemoglobinuria versus myoglobinuria. Both are going to produce clear red urine. Both are toxic to the renal tubules. Hemoglobin causes red plasma. Myoglobin will have a clear plasma. Increased CK enzymes will also accompany myoglobinuria since it's related to the muscle. The reagent strip reaction, so the chemical tests for blood use what's referred to as the pseudoperoxidase activity of hemoglobin to catalyze a reaction between the heme component of both hemoglobin and myoglobin and the chromogen, tetramethylbenzidine, and hydrogen peroxide, so those are your reagents, to produce an oxidized chromogen, which is a green to blue color. Color charts are provided that correspond to the reactions that correspond with either hemoglobinuria, myoglobinuria, and hematuria. Free hemoglobin or myoglobin will produce a uniform color on the reagent strip, ranging from yellow to green to a strongly positive green or blue. Intact red cells are lysed when they come in contact with the pad, and that released hemoglobin results in a speckled pattern on the pad. Strips can detect as few as 5 red cells per microliter. Okay, some reaction interferences. False positives could be due to menstrual contamination, strong oxidizing detergents present in the specimen container, vegetable peroxidase, and bacterial enzymes, including E. coli peroxidase. False negative reactions could be due to ascorbic acid, but the strips have been modified so that only very high levels will interfere now. When urine with a high specific gravity contains crenated red cells that do not lyse when they come in contact with the pad. When formalin is used as a preservative, hypertension medication, captopril, high concentrations of nitrite, and then failure to mix the specimen because the cells settle to the bottom. And the next test is bilirubin. So the presence of bilirubin can provide an early indication of liver disease. It's often detected long before the patient exhibits jaundice. So bilirubin is a degradation product of hemoglobin that has a very strong yellow pigment. The normal lifespan of a red cell is about 120 days. And once they are destroyed by the spleen and liver, the hemoglobin that is released from the cell is broken down into iron, protein, and protoporphyrin, which is a different kind of protein iron complex in hemoglobin. The iron and protein can be reused by the body, but the cells of the reticuloendothelial system convert the protoporphyrin to bilirubin, which is then released into circulation where it binds with albumin and is then transported to the liver. So the kidneys cannot get rid of it at this point because since it is bound to protein, it's too large to pass through the glomerulus, but it is also water insoluble at this point, which at this point it's referred to as unconjugated bilirubin. So in the liver, the bilirubin becomes conjugated or joined with glucuronic acid by the enzyme glucuronol transferase. It's now water soluble and it's now called bilirubin diglucuronide. You would normally not see conjugated bilirubin excreted by the kidneys because it goes from the liver into the bile duct and then to the intestine where bacteria reduce it to urobilinogen. Some of that is then excreted into the feces as stercobilinogen and urobilin, and some is excreted by the kidney. And here's just a visual representation of that process that's happening. Clinical significance of bilirubin in the urine. So only conjugated bilirubin is capable of appearing in the urine. And this is because unconjugated is too large because it's attached to that protein and it's water insoluble. When conjugated bilirubin is appearing in the urine, it is because either the normal degradation cycle has been disrupted by a bile duct obstruction, which is known as post-hepatic jaundice, which is also seen in gallstones or cancer, or when the liver is damaged, such as is seen in hepatitis. So either of these conditions could lead to leakage of bilirubin into circulation. So why would a bile duct obstruction be known as post-hepatic jaundice? That's because the conjugated bilirubin normally goes from the liver to the bile duct, so which is after the liver. So if there's a problem in the bile duct, then it is considered post or after the liver. So because of this, the detection of bilirubin in the urine can be an early indicator of liver disease, but it is also helpful in determining the origin of jaundice. So using the bilirubin results in combination with the urine urobilinogen results can help even more in determining the cause of jaundice. And there's a table in your book, and I think it's also in, yeah, it's in the PowerPoint here, but just a little bit farther down. You can use those urine bilirubin and urobilinogen results to determine the cause of jaundice. So just take a look at the variations that you're seeing in the results comparatively here between bilirubin and urobilinogen and what condition that is associated with. Okay, let me get back to the slide that we were on. Okay, reagent strip reactions. So the principle of the test is what's known as a diazo reaction. In the reaction, bilirubin reacts with a diazo salt, which is a type of organic compound, and there's a different salt used for each manufacturer of strips, in an acid medium to produce an azo dye. The color results can range from tan to pink to violet. Color reactions for bilirubin are more difficult to interpret than other reagent strip reactions and are also easily influenced by pigments present in the urine. So some reaction interference, false positive, could be due to urine pigments, especially the bright yellow, orange urines that result from a person who is taking azo. The color in these urines can sometimes be mistaken for bilirubin on initial observation. Also, the medication Lodine, which is an anti-inflammatory, can cause false positives. False negatives could be due to old specimens because bilirubin breaks down in the presence of light, which is referred to as photooxidation. So it breaks down to biliverdin, which will not react with the diazo tests. Also, when the hydrolysis of bilirubin diglucuronide produces free bilirubin, because this is less reactive in the reagent test strips, large amounts of ascorbic acid or nitrite can lower the sensitivity of the test because these substances can combine with the diazo salt and prevent its reaction with the bilirubin. And ictotests, so I think this was the last confirmatory or backup test that we referred to in lecture 1. It's a confirmatory test for bilirubin. The test consists of special test pads and tablets, and a blue or purple reaction is considered a positive. So the procedure, you're going to place 10 drops of urine onto that special test pad that comes with the reagents. The tablet is then placed on the center of that wet area on the pad. A drop of water is placed on the tablet. You have to wait 5 seconds and then flush the tablet with water so that the water runs over the side of the tablet onto the mat. Wait 60 seconds and look for blue or purple color on the test pad. Okay, and that you can kind of barely see. There's that special test pad that's made for your ictotest tablets. Okay, urobilinogen. So as we just talked about, bilirubin eventually is converted to a combination of stercobilinogen and urobilinogen. Some of the urobilinogen is excreted in the feces, but some of it is reabsorbed from the intestines into the blood and will appear in the urine because it passes through the kidney and is filtered by the glomerulus. Because of this process, a small amount of urobilinogen is normally found in the urine, usually less than 1 milligram per deciliter. Okay, clinical significance. So increased urine urobilinogen is seen as in liver disease and hemolytic disorders. Therefore, the measurement of urine Urobilinogen can be a detector of early liver disease. If there is something wrong with the liver and it cannot function properly, then it would not be able to process the urobilinogen. And so the excess remaining in the blood is filtered by the kidneys and will appear in the urine. Jaundice associated with hemolytic disorders is the result of increased amounts of unconjugated bilirubin. The unconjugated bilirubin goes to the liver for conjugation, which causes an increase in the amount of conjugated bilirubin going to the intestines. Therefore, increased amounts of urobilinogen are produced, increased amounts are reabsorbed into the blood and to the kidneys for filtration. So because of that whole process of excess, the liver is not able to keep up and so cannot process the reabsorbed urobilinogen, and in turn, excess is presented for urinary excretion. The absence of urobilinogen in the urine and feces is also significant, although this cannot be determined by the reagent strip reactions. Absence represents a bile duct obstruction so that the normal passage of bilirubin into the intestines is prevented. Okay, the reagent strip reactions. The test pad for urobilinogen is where the most difference is seen in test methods between the two major manufacturers. So Multisticks uses what is called an Ehrlich's aldehyde reaction. ChemStrip uses an azo coupling or a diazo reaction. So the multi-stick reaction, urobilinogen reacts with the reagent in an acid environment to produce a color reaction ranging from light to dark pink, and the test is reported in Ehrlich's unit, where 1 Ehrlich unit is equivalent to 1 milligram per deciliter. ChemStrip reactions, urobilinogen reacts with the ChemStrip reagent in an acid environment to produce a color reaction ranging from white to pink and is reported in milligrams per deciliter. This reaction is more specific for urobilinogen than the Ehrlich reaction. Okay, some reaction interferences. There are a lot of false positives possible with the multisticks because of the Ehrlich's reagent. Some reactions or substances that react with Ehrlich's are porphybilinogen, which is something formed during the synthesis of heme, indican, which is a substance formed by the decomposition of tryptophan in the intestines and excreted in the urine. Also sulfonamides, methyl-dopa, procaine, chlorpromazine, and p-aminosalicylic acid. Ehrlich's reaction increases in sensitivity as temperature increases, so it's important to make sure that the test is being performed at room temperature. Highly pigmented urines and bile salts present in a sample, which could be common after a meal, can also cause erroneous results. And then false negative results are seen most commonly as a result of improper preservation of the sample, which allows urobilinogen to be broken down or photooxidized to urobilin, and can also be seen when there are high concentrations of nitrite, but that would be in your ChemStrip only. Okay, the Ehrlich tube test. The 6th edition, which I think you guys are on the 7th edition of the book, does not talk about these tests, and if the 6th edition doesn't talk about it, the 7th probably doesn't either. So it doesn't talk about the tests at all, so we're only going to learn the most very basic information. So for Ehrlich, just know that it is a test that was used before the reagent strip testing method was developed, and this method was modified into the Watson-Schwarz test to differentiate between urobilinogen, porphyrilinogen, and Ehrlich reactive compounds. And then the Hoesch screening test can be used for rapid screening or monitoring of urinary porphyrilinogen. Okay, the next test on the reagent strip is nitrite. Clinical significance of this test: the nitrite reagent strip test is useful as a rapid screening test for UTI. So it's useful in detecting initial bladder infections, also known as cystitis, when patients are usually asymptomatic. If left untreated, cystitis could lead to more serious complications like pyelonephritis, renal tissue damage, and even septicemia. The nitrite test can also be used to monitor antibiotic therapy and to screen patients who have recurrent UTIs or who are more prone to UTIs, such as diabetics and pregnant women. The reagent strip reaction. So nitrate, which normally appears in urine, is broken down by certain bacteria that have the ability to reduce nitrate to nitrite, which does not normally appear in urine. This is detected by what is called the grease reaction, where nitrite in an acidic environment reacts with an aromatic amine to form a diazonium compound that then reacts with the reagent compounds to produce a pink colored azo dye. False positive reactions are prevented because the reaction is standardized to correspond with a urine culture of 100,000 organisms per milliliter. Different shades of pink can be produced on the reagent pad, but any shade of pink is considered positive and does not measure the degree of bacteriuria. There's your representation of the reaction that is occurring. Okay, some reaction interference, false negatives. So some bacteria do not produce the enzyme reductase, so they cannot reduce nitrate to nitrite. Only the gram-negative organisms can produce reductase. So an infection with a gram-positive organism or a yeast would not be detected by this method. So that doesn't mean that the patient doesn't have a UTI. It's just not with one of those gram-negative organisms that are able to reduce nitrate to nitrite. Testing performed on random samples would be less likely to have a positive reaction because the bacteria capable of reducing nitrate must remain in contact with the urinary nitrate long enough to produce nitrite, which takes 4 hours. It also depends on the amount of nitrate actually in the urine, which comes from a normal diet. So nitrite is used as a meat preservative. So it's found in hot dogs, bacon, lunch meats. So a patient that is deficient in nitrate would not have enough to produce a positive reaction because there's nothing for the bacteria to reduce. And when very large numbers of bacteria are present, nitrite may be reduced even further to nitrogen gas. Inhibition of bacterial metabolism because of antibiotics. If there's large quantities of ascorbic acid, decreased sensitivity in specimens with a high specific gravity. So a lot of different conditions there that could cause a false negative. And then false positive would be due to an improperly preserved specimens and highly pigmented urines. Okay, and then I think this is the last test that we're going to talk about here, the leukocyte esterase. So this used to be done by microscopic exam only, which was subject to a lot of variation. So the chemical test provides a more standardized means of detection. The test does not measure the concentration of leukocytes, so quantitation should be done by the microscopic exam. However, the test is capable of detecting leukocytes that have been lysed, which would not appear on the microscopic. Okay, the clinical significance of this test. Normal values range from 0 to 2 to 0 to 5 white cells per high power field. Women tend to show more just due to vaginal contamination. Increased urinary white cells are an indicator of UTI and most commonly will accompany the presence of bacteria in the microscopic. But as we said before, the bacteria may or may not be able to produce a positive nitrite reaction. The leukocyte esterase detects the presence of esterase, which is an enzyme that hydrolyzes an ester into an alcohol and an acid. This is present in the granulocytic white cells, so that's your neutrophils, eosinophils, basophils, and also in monos, but not in lymphs. Esterases are also present in trichomonas and histiocytes, which are types of tissue cells. So you could get a positive leukocyte esterase reaction from something other than actual leukocytes. Neutrophils are the white cells most commonly associated with UTI. There are some types of infections, though, that can cause a positive leukocyte esterase that would not produce a positive nitrite or would not show bacteria in the microscopic. So if the patient had a trichomonas infection, had chlamydia, yeast, an inflammation of the renal tissues, so this test can be used in conjunction with the nitrite test to determine the need for a urine culture, but the leukocyte esterase test can be a good predictor of urine culture need even without the nitrite test. Okay, the reagent strip reaction. So the principle of the test is that leukocyte esterase catalyzes the hydrolysis of an acid ester that is in the reagent pad to produce an aromatic compound, an acid, which is called the indoxyl carbonic acid ester reaction. So the aromatic compound, which just means that its chemical structure forms a ring, then combines with the diazonium salt that is in the pad to produce a purple azo dye. This test requires the longest amount of time of all of the tests on the reagent strip. So this one takes 2 minutes. It's the last one to be read. Okay, some reaction interference. False positives could be due to strong oxidizing agents or formalin in the container, highly pigmented urines, and the antibiotic nitrofurantoin. False negative reactions could be due to high concentrations of protein, glucose, oxalic acid, and ascorbic acid, some urines with a high specific gravity, certain antibiotics, and if the test is not read at the correct time. Okay, and I was wrong. Specific gravity is the last test that we're going to talk about. So the reagent, and we've already talked about specific gravity a good bit previously, but this one is on the reagent strip pad. So the reagent strip reaction, this is based on the change in dissociation constant of a polyelectrolyte in an alkaline medium. The polyelectrolyte ionizes and causes the release of hydrogen ions in proportion to the number of ions in the solution. So the higher the concentration of the urine, the more hydrogen ions are released, which lowers the pH. The reagent pad uses an indicator in the pad called bromthiamyl blue to measure the change in the pH. So as the specific gravity increases, the indicator changes from blue to green to yellow. This is the preferred method to use for patients who are on plasma expanders or radiographic contrast media. And then some reaction interference. False negatives can be due to highly alkaline urines, so those that have a pH of 6.5 or higher. They'll give decreased readings because of interference with the indicator with the bromthiamyl blue. So when reading the results manually, it's recommended to add 0.005 to the result. You would not have to do that correction for automated readers because they perform that correction already. And then false positive reactions could be due to high concentrations of protein. Okay, that is the end of the Unit 2 lecture. So we have covered all of the tests that are on the urinalysis reagent strips, and just make sure that you also watch the supplemental videos in Moodle of some of the tests that we talked about.